afternoon, Ananor. All of you, welcome to this Zoom platform of Sri Gokulam Nursing College. Today we are conducting a webinar series 3 on COVID-19, a global perspective. Till now, in the previous webinar sessions, we got a lot of information regarding COVID-19, that is how it is affected in Kerala and India. But as a healthcare worker, it is important to know how the COVID-19 affected globally and what are the policies and protocols adopted by various governments to control COVID-19. Today we have very distinguished group of speakers to discuss the various policies and protocols of COVID-19 in 3 different countries. Our speakers are firstly Ms. Simi Ann Nelson, Director of Nursing, the Alzheimer's Society of Ireland. Then Ms. Shinjo Jose, Neuro-Hospitalist, Presbyterian Hospital, Columbia University, New York. Then Ms. Jasmine Whitin Anthony, MSc Certified RN Anesthetist. She's also working in the same hospital. Then Mr. Daniel Wilfred, Clinical Nurse Specialist, Vancouver Based Hospital. I would like to welcome all these eminent speakers to this webinar session. Once again, I would like to welcome all the participants to the webinar session. For the participants, if you have any doubt, you can ask in the chat section. Okay, we can move on to the webinar sessions. The first session is by Ms. Simi Ann Nelson, Director of Nursing. Welcome you, ma'am, to the...
Thank you very much. Good afternoon, everyone. It gives me great pleasure to be a part of this global webinar. I would like to take this opportunity to thank all the hosts, the organizing committee, who have worked behind the scenes to establish this global event. Let me also extend my gratitude to all who have worked behind the scenes and taking great effort, especially Mrs. Bindu CG, the Vice Principal of Sri Gokulam Nursing College, for her commitment, her contribution, and leadership. Here I am today going to reflect on the strategies that Ireland implemented during the COVID-19 pandemic. Can you see my screen?
No, ma'am. No.
Okay.
Can you see it now?
Yes.
Okay. So I'm just going to briefly run through the introduction, the objective, what we did as a country to flatten the curve in Ireland, how we prepared ourselves as a country, how it began the epidemiology, the easing of restrictions, and how in the hospitals they managed to curb the plateau. Coronavirus, as we all know, is a novel disease that was not previously seen in humans and initially identified in Wuhan, China, this is an infection caused by a virus called severe acute respiratory syndrome. The outbreak was declared a public health emergency of international concern on 30th of January 2020 and a pandemic by the World Health Organization on 11th of March with serious levels of concerns about the spread and severity of the illness. Although it's a new virus, knowledge is accumulating rapidly about the characteristics of the virus, the cause of the illness, the manner of transmission, and the management of those who acquire this infection. COVID-19 pandemic has led to unprecedented interruption to normal healthcare activity in Ireland, with both community and acute settings affected. The anticipated high volume surge in COVID patients in Ireland was flattened by close adherence to public health advice and levels of capacity within the health system, which were becoming available for the services. So the COVID-19 pandemic has led to unprecedented interruption to normal healthcare activity in Ireland, both within the community and acute settings. The anticipated high volume surge was flattened due to close adherence to public health advice. Ireland had made advanced plans in place as part of its comprehensive preparedness to deal with public health emergencies such as COVID-19. So the three main strategies that Ireland put in place was number one, the containment strategy. In the containment phase, the focus was on all the cases, no matter how mild. In this phase, irrespective of case severity, all efforts are focused on identifying the cases and their contacts early enough to prevent further transmission. In the delayed phase, initiatives were put in place to slow the spread of the virus. Ireland is currently in the delay phase. We know that COVID-19 is contagious. Many people will catch it. So the delay strategy is planned to slow down the spread of the virus. This means, like, for example, if 1,000 people were going to catch the virus, the delay initiatives should result in 200 people per week catching the virus over 5 weeks rather than 500 people per week catching the virus over 2 weeks. That was the way that we were able to reduce the burden on the doctors and hospitals. In the last strategy, the mitigation strategy, the focus is on the cases experiencing most severe symptoms. This will be activated when containment is no longer effective in controlling the spread of COVID-19. In this phase, our focus will be on identifying the cases which were severely unwell. Now, just a brief on how everything began in Ireland. In February 29th, the COVID-19 pandemic reached the Republic of Ireland. March 12th, government shut all schools, colleges, childcare facilities, cultural institutions, and advised canceling large gatherings. March 21st, cases had been confirmed in all the counties within Ireland. The pandemic had affected many aspects of the society. March 24th, all businesses, venues, facilities, and all amenities were shut. March 27th, 3 days after that, the government imposed a stay-at-home order. In other words, the country went into lockdown, banning all non-essential travel or contact with people outside one's home. The elderly were advised to stay at home, otherwise known as cocooning. People were made to keep apart in public, and even the police were given power to enforce these measures. This next slide is just a short table of how you can see how the numbers rose from one month to the other, like the number of confirmed cases, the number of new cases per day, the number of cases which were hospitalized, the number of cases that were admitted in ICUs, and number of deaths. So you can see a huge steep growth in the graph. In March from 64, in May it was 1390 number of deaths, and in August it's 1519 at the moment. Okay, and then now the plan how Ireland has established on easing of the restrictions was in 5 phases. So after the lockdown situation in March, the government decided to ease the restrictions and step into phase 1 on the 18th of May. So on the 18th of May, the government advised that outdoor meetings between people from different households were fine. Childcare facilities were open up for healthcare workers. There was a phased return of outdoor workers, opening of certain outdoor public amenities. So at phase 1, to compare with the number of new cases, like when the restrictions was eased off, on that particular day, there was new cases of 143 and number of deaths was 20. The previous day before the easing of the restrictions, the number of new cases was 112 and number of deaths was 10. So you can see a significant rise in the number since easing of restrictions. Phase 2 was on the 8th of June, where visits between households were permitted. They developed plans to open up businesses with consideration for safety of the staff, open up small retail outlets where social distancing was observed, and open up public libraries. And in this case as well, on the 8th of June, the day the second phase was stepped into, there were 6 cases, new cases on that particular day, and number of deaths was 2. The previous day, it was 8 and number of deaths was 8. Phase 3, which was we stepped into on the 29th of June, small social gatherings were permitted, opening of creche, childminders and preschools came returned to work, and playgrounds was opened. Now, this was reviewed every week, and due to the sudden surge in the number of positive cases, we are still on phase 3 at the moment. So on June 29th, as you can see, the number of new cases on that particular day was 9 and number of deaths was 2. The previous day, it was 24 and number of death was 1. Okay, and next is just the phase 4 and phase 5, where definitely there'll be larger social gatherings permitted, return to work across all sectors, and there'll be opening of all the schools. The roadmap which Ireland has set was a framework for future decision making, which will always be underpinned by public health advice. The government regularly reviews the following, which is the latest data regarding the progression of the disease, the capacity of the health service, capacity of testing, tracing system, and the measures that we have in place to protect the vulnerable groups. Okay, so initially when we had the first COVID outbreak, how they managed in the hospitals was all the hospitals, suddenly there was 2 separate sessions divided into, like partitions were built. So there was a COVID area and a non-COVID area. There was a COVID team that was appointed to do preliminary testing on every patient who stepped into the hospital. They were initially kept on isolation, and while they were waiting for the results. So if they were positive, they were directly admitted into the hospital. If the results were negative, they were asked to go back home and advised be on self-isolation for 14 days. So given the circumstances with the sudden surge in the number of positive cases, the government had to stop all outpatients appointment and elective surgeries. Some of the theaters were repurposed to hold 2 to 3 ICU beds for patients on ventilators. Patients who developed severe respiratory symptoms were transferred to ICUs, and all those who required ventilator support. The therapeutic measures implemented initially was azithromycin, was the medication that was used, as it produced positive outcomes in some cases, not all, particularly those who had pneumonia and respiratory failure. In all other cases, results have been inconclusive, according to a HSE bulletin on the 2nd of April. Prepared by the COVID-19 Rapid Evidence Review Group, the bulletin reports on 2 studies. So in one of the studies, 80 patients who were treated with azithromycin showed positive outcomes from the combination theory, with although there was a negative viral load in 83% of the cohort on day 7. In another study, 11 patients concluded there was no evidence of rapid antiviral clearance or clinical benefit. But if this treatment was successful, they also said that they supplement the supportive care where patients receive intensive care unit to help them breathe and keep their organs functioning. The second measure that was implemented was contact tracing. In this, what happened was the person who was positive would have to talk to the clinician and give them details of the places they visited and the people they came into contact. This was given so that a detailed picture of all this person came into contact was taken into account. Staff who came into work was supposed to log in to this record where are the places they visited and who the people they contacted with. This was to facilitate tracing in the event of an infection. The HSE, High Consequences Infectious Disease Planning and Coordination Group, has been working in a detailed level on this situation, and they put detailed plans in place to help the country face this situation. Ireland will continue to monitor the global development of this new virus and respond accordingly. Another huge challenge we faced as a country was staffing. There was significant staff redeployment taking place because certain units in the hospital, certain wards had to be closed down so that they would be made available to work in ICUs and all other, acute emergency situations. So returning these staff to previous roles was a huge challenge. Right now, like what we did since March was the healthcare workers who tested positive were advised to self-isolate at home for 14 days. Healthcare workers who were tested positive but were unable to self-isolate at home were given accommodation in hotels, which was arranged by the HSA. Are you okay? Staff who were not positive, but who were providing care to patients and residents and vulnerable clients were provided with accommodation as well, because there was no facility to self-isolate at home. It was a challenge in maintaining necessary staffing levels because of the ongoing infection prevention control systems and all the PPE requirements. And then another system, another strategy that we found very effective was closely adhering to the public health notices for all the centers across the country. There was mandatory training made available for all the staff to meet the challenges in the circumstances. All the staff had to undergo mandatory infection control training of how to don and doff the PPE while caring for a COVID patient. Hand washing was made very strict, and there was notices put all over the center to promote hand washing and to remind staff the importance of hand washing. Hand sanitizers were made available at all locations. Staff were instructed to work from home as much as possible, where the workplace did not have an environment where they could keep a distance of 1 meter to 2 meters. So they were all advised to work from home as much as possible. On 18th of August, the government announced additional public health measures, including that people should work from home unless it is absolutely essential for them to attend in person. Then there was a restructuring of the teams at work. First and foremost, an isolation unit was organized. All healthcare facilities where residents were positive were isolated immediately to control the spread. Selected staff members were allocated for the isolation unit and to work in the COVID positive unit. Those staff members had a separate entrance to enter and exit the building. There was a separate PPE stock made available, and housekeeping staff were assigned to ensure that this isolation unit was perfectly clean with enhanced cleaning measures. Limited staff to the canteen, restructuring of staff allocations, and staff breaks were all changed in order to limit crowding in staff rooms. Additionally, what we did was there was communication in place every single day to keep all the employees informed of the changes in the practice. A coordinator was appointed. This coordinator took complete responsibility to make sure that there was adequate staff in the respective units, provide regular updates on changes in the practice, provide information and policies and procedures, promote the importance of hand hygiene, to keep up to date on the issues, the resources for the operation at home, in community centers and hospitals. It was crucial to have staff meetings to ensure everyone took care of their own mental well-being, physical health during the pandemic, to ensure their availability and suitability for continued work. The coordinator would also keep regular contact with the staff who were on self-isolation. Now, there was a workplace protection and improvement guide implemented. So we had to do a regular COVID drills within the center to make sure all the staff who were on board understood the do's and don'ts of if a resident suddenly became positive or presented with symptoms. The coordinator was responsible to make sure all the risk assessments were in place in adherence to the National Public Health Team. Staff were informed, families were informed. All staff had to constantly be reminded about the correct procedure for donning and doffing of PPE, and that any mistake would defile the purpose of the steps. If the steps were not followed appropriately, the doctor had to be informed, and staff who were tested positive were reminded regarding self-isolation and other prevention measures. Housekeeping staff, they were particularly given training as well initially in regards to the cleaning of the area. If there was a suspected case, the cleaning staff were provided with adequate PPE, disposable gloves, and all the gowns required. They were taught how to change the PPE the way that the government had advised, in accordance with the whole public health system. All PPE should be carefully removed and disposed to minimize the risk of contamination. The most important surfaces was to clean and disinfect regularly the surfaces where the staff were constantly touching. For example, the keypads, touch screens, door handles, hoist handles, side rails, etc. And then to ensure that the area in which the task was undertaken was well ventilated during the cleaning and disinfecting process. A record of the cleaning was to be maintained, the date and time of cleaning, the rooms that they cleaned. There was a requirement to conduct contact tracing if the person had become positive with the disease. And here to conclude, my advice to everybody who's listening to me is to stay safe. We have all learned to live with COVID at the situation. Everyone is urged to use their own judgment and take personal responsibility for protecting themselves and others. Everyone should be aware of the risk factors for getting COVID. The key points, I have just briefed it up into dates. Okay, D is for distance. The risk of getting COVID increases as the distance between two people gets smaller. So keep 2 meters apart where possible. Activity, how would you spend your time with people and what you do with them can increase your risk. Follow the government's stay safe guidelines when spending time with others. T is for time. The more time you spend in close contact with other people can increase your risk for getting COVID. Keeping track of who you spend time with and how. E is for environment. Being outdoors is safer than indoors. Where possible, meet with others outdoors. If this is not possible, keep windows and doors open when meeting others inside. S is for symptoms. Know the symptoms. If you have them, self-isolate and contact your doctor immediately. I thank you all for listening to me patiently, and I hope this session was informative and interesting. Thank you very much.
Thank you, Simi. Thank you for your time and the pain you took for the presentation. And I know ഞാൻ കുറച്ച് നല്ല രീതിയിൽ പെയിൻ തന്നു എന്ന് എനിക്കറിയാം. So ഇനിയും പ്രതീക്ഷിക്കാം ഇങ്ങനെയുള്ള presentations. And thank you so much. Now I'll invite Shinda Jose, neurohospitalist, and in the hospital it's too difficult to pronounce actually, Presbyterian Hospital and Columbia University. Actually, we are hearing this hospital name frequently after since the COVID-19 pandemic, because in US this hospital is the biggest hospital, almost a 2,000 bedded hospital, and we know how badly it is pandemic affected in New York. And she's working, Shinda Jose is working over there in ICU, and Jasmine also working over there. And these are the two persons first line managing the COVID patients. Actually, these are the persons. So these participants, please utilize and ask many questions to them and get to know what's actually happened in New York and what are the policies and protocols. Shinda, I welcome you for the presentation.
Hi, good afternoon to all who are attending this webinar. My name is Shinda Jose, and I currently work at Columbia University in New York as a neurohospitalist. I'm so grateful to Bindu and also Sri Gokulam Nursing College for giving me this opportunity to share my experience as a critical care clinician managing the pandemic in US Epic Center. Can you see my screen?
Yes.
Yeah, we can see.
Okay. As Bindu said, Columbia University Medical Center is a academic medical center and the largest campus in New York Presbyterian Hospital System, and we have the capacity of 2,006 200 beds, and also our ventilator capacity before COVID was 250, and during the COVID time, our ventilator capacity extended up to 1,000 beds. And we always receive transfers from the smaller surrounding hospitals, and we have about 5 adult ICUs that has so many other subspecialties, as well as we have pediatric and neonatal ICUs and several step down units. As New York City became the global epicenter of the COVID-19 pandemic around the spring of 2019, our campus had creatively expanded our caregiving capabilities in multiple ways. Some of the measures taken include: the first thing, we focused more on the infection control. Then we have to meet all these clinical operational challenges. Next thing we did was increase our ICU surge capacity. Then we focused on the staffing and ethics. Another important thing we focused was the maintenance of staff wellness. Immediately, the hospital developed protocols focused on clinical decisions regarding intubations, use of high flow oxygen, engagement with infectious disease consultant, and cardiac arrest. Then we taken measures to increase our bed capacity and increase the efficiencies in ICUs by outsourcing procedures were implemented. And also we started novel use of technology to minimize the staff exposure to COVID-19, as well as to facilitate the family engagement, and end-of-life discussions were encouraged. And the most important thing during this time was the education and communication, so that we can standardize the care throughout the hospitals, and also keep informing our staff the emerging data. And we had so many literature reviews on the respiratory failure. And we had so many challenges during this period, but we overcome those through interdisciplinary collaboration and also surge planning as ICU admission increased. Here are some approaches we used in our hospital, and it gives a potential roadmap for the centers that must rapidly adapt to the tremendous challenges posed by this and potential future pandemics. So the first thing we did was the infection control. So what we did in our hospital was, once we found that COVID-19 is becoming more and more aggressive in New York City, we started, our initial planning was with collaboration with our hospital epidemiologist and the infection control staff. And also we depend so much on the CDC guidance as every day there was like new information coming from CDC. CDC is the Center for Disease Control that controls the whole US with the informations. And also this epidemiology team, they rapidly educated the hospital staff about donning and doffing of PPE, and online videos and education materials were distributed throughout the hospital. The clinical challenges, we had many kinds of challenges, so we went through, I'm going to discuss all of them individually. So the first thing was, as the COVID-19, the most important thing the people were suffering was respiratory failure. So the first and foremost decision was whether to intubate them or not. So initially we thought, depending on the mode of transmission of COVID-19, we were like not using much of the high flow or the nasal cannula kind of oxygenation. But as our number of patients increased, we had to use high flow nasal cannula. But we started to use those high flow nasal cannulas in a negative pressure rooms, so that we could avoid the spread of the disease, as well as avoid the need for intubation. Then the decision comes to intubate people, where we use the clinical judgment of the critical care physician. And most of the time they based their decision depending on the factors like hypoxemia, tachypnea, increased work of breathing, and gas exchange. Then once we made the decision to intubate, then we had to have the teams to do the intubation. So immediately the hospital adapted a airway policy, and then we created teams for intubation. So in that team, we included the most experienced person to intubate the patient, and we had a rapid sequence induction, and also we used video laryngoscope so that we could avoid multiple trials of intubation. And usually it's the critical care doctor identifies who needs the intubation, and immediately we notified the COVID-19 intubation team, and the team comprises of an anesthesiologist or a respiratory therapist and a critical care nurse. And we made 2 teams in our hospital for intubation COVID-19 teams, and they were available for 24 hours, 7 days a week. And they were only dedicated for COVID-19 intubations. The next step we took was engaging with infectious disease consult. Given the infectious nature of the disaster and rapidly evolving therapeutic landscape, infectious disease consultants were immediately started to have a dedicated COVID-19 team and a COVID-19 pager. So this team was like coming to every critical care units, and they were like doing rounds with all these patients, and they were giving us information and as well as giving us advice about the kind of treatment, whether antibacterial, antiviral, and the potential new trial drugs. And also they serve as a gateway to rapidly evolving therapeutic trials. Then next step was extracorporeal organ support. As you know, it's like ARDS, when the patients are in ARDS, multi-organ failure also was going on. So some of the patients required ECMO. So then we have to make the decision who will be the potential person to undergo for ECMO. So there was a critical care doctors, and they will discuss the case in a multidisciplinary team, and then they made the decision who will get the ECMO support. Then most of these COVID-19 patients had like renal failure. So there was a renal team also dedicated only for the COVID-19 patients. So they decide renal replacement we have offered to most of the patients who had acute or chronic renal failure, and we used either traditional hemodialysis methods or continuous venous hemodialysis, and also we use sometimes peritoneal dialysis to accommodate the number of patients we encountered during this time. The next challenge was the cardiac arrest. As you know, we had so many deaths in New York City, so we had to make the decision about the cardiac arrest, what to do and who to do the CPR. So immediately the hospital instituted institutional cardiac arrest policies, and so that the purpose of the policy was to limit the number of people exposure to the COVID-19 patients. So to avoid the contact with these COVID-19 patients, we immediately started to use mechanical compression devices that ease off our burden to having contact with the patient during these arrest situations. And also the ICU arrest or the resuscitation was conducted in a standard fashion. Next step was standardization of care across all critical care delivery areas. As you know, our hospital has so many different ICU settings. As the disease progressed or the number of patients rose, so we had to convert our OR, cardiac caths, all step downs into ICU. So it's like too many places to manage. So in order to avoid any confusion and chaos, we had a pulmonary critical care team. They took over for all the ICUs. They came to each of the ICU and to have rounds with the other teams of the ICU, and they give us education about how to take care of the arts protocol, and also they had given multiple education, and also we had daily email updates so that we will have access about what to do and how to manage these patients during this pandemic. The other thing was we used is approaches to efficient use of our times in the ICU. The one thing we did was we had like dedicated smartphones with chargers were placed in each patient's room. So once the staff member enter in the room with the PPEs, and if they need additional help, instead of coming out of the room by removing the PPE, they could call. And there was always a buddy system, so there was always one nurse outside, so that person can bring the supplies whatever they needed. And also we had like a dedicated procedure team to perform all the ICU procedures such as central line, arterial line, nasogastric tube insertion, and other like kind of lines for dialysis round of clock. And also we had a tracheostomy team, so they did all the tracheostomy in the ICUs. Then the other treatment modality we used in these patients was proning. So there was a specific team assigned for proning that comprised of critical care medicine and as well as physical therapy staff, and so that we could use ICU staff for other purpose instead of taking their time for pronation and supination of patients. And we did so many innovative adaptations during this pandemic time. We had like all the ICUs with glass doors, so the door we used to write the rate of the drips, the ventilator settings, because every minute, every hour the ventilator settings were keep on changing. So instead of going inside the room and to check on these settings, we wrote all these data on the doors, and also the blood gas results, so that everybody in the team will be aware of what was going on with the patient's condition instead of going inside each room. Then we had taken many steps to minimize exposure of our staff to the COVID-19 patients. So whenever we did the care, we bundle much of the care, like once they go to the room, they give medications, they do all the lab works, and also instead of going and changing the medications every time, to reduce the frequency of going to the room, the pharmacy was preparing large bags of intravenous fluids, and sometimes we even concentrated our solutions. Then so many imaging studies and EKGs, things like we routinely do, were limited during this time. And most of our IV pumps, and all these patients were on multiple drips and vasoactive drugs. The pumps were placed outside of the room with extra intravenous tubings. As I said earlier, a buddy system was also included. So one staff member was available to manage the medication pumps and also to deliver boluses and things needed when the assigned nurse was inside the room. Then education was the key in all management. So pulmonary and critical care physicians created a rapid simulation curriculum and was provided for both day and night shift nurses in non-medical ICUs. Because for non-medical ICUs, this was they were not as prepared to manage our ARDS like medical ICU specialized people. And also we had multiple remote access conferences and journal clubs conducted frequently, and the topics of those educations were fluid management, ventilator management, pronation, sedation, and so many other things. The next clinical challenge we faced was communicating with the families. As you know, with the COVID-19, we had visitors restrictions. So we had to assign one of the family member as the information taker, and every day the physician or the advanced care practitioner had communicated with the family, and also the palliative care team was also contacting the family members. And if there was an imminent death or was expected, then we allowed one family member with PPE to come and see the patient. And also we used video conferencing, Zoom, and also FaceTime, so that the family can see their loved ones and also was able to speak with their dying family member. Then next one is ICU surge. All critically ill patients without COVID-19 were grouped together in distinct or newly created ICUs. Elective surgeries were reduced to minimize the surgical admissions and to preserve PPE. As units were opened and full, additional units were rapidly identified. We began to care for patients with COVID-19 even in operating rooms. Similarly, step-down units and recovery rooms were rapidly converted to COVID-19 ICUs. Next one was efficient bed management. Even before the COVID-19, we had a patient placement operation center was controlling all our admissions. So during this pandemic time, we included one of our critical care physician, also partnered with the nurses who were working on the patient placement operations to triage all the patients who needed to go to these ICUs, and also facilitated transfers from other hospitals and also within our New York Presbyterian system. Next is staffing. So as you know, the number of patients rising and the number of ICUs were rising. So we had difficulty in managing the staffing. So ICU staffing, the physician staffing has been rapidly expanded. Additional pulmonary and critical care physicians and critical care anesthesiologists have been redeployed to units with the goal of achieving a ratio of 2 senior physicians with at least 1 intensivist for every 20 patients in the ICUs. And also we got redeployed all the advanced care practitioners from outpatient and also from ambulatory cares to ICUs. Additional hospitalist trainees and physician extender teams were redeployed to provide patient care round the clock, as well as to provide medical expertise to non-medical intensivists. Next, we were lucky to have a very good research faculty in our campus. So all our ongoing researches were limited to focus more on the COVID-19. Our institution has started on multiple clinical trials for possible therapeutic agents, and our institution was approved most of these studies, and we conducted many of the clinical trials during this time. Next thing was focus on the respiratory and the nursing staffing, because as the ICU numbers are rose, most of these nurses are not trained as critical care nurses. So we need to have trained these people by shadowing the ICU nurses, and also we had to give them so many education and training fairs to teach ICU skills, so that the nurse and the respiratory therapists were equipped to manage the critically ill patients. Next, our non-clinical staff also helped us during this pandemic time. Especially our environmental service staff members became expert at donning and doffing of PPE and clearing of the refuse at an accelerated rate in COVID-19 rooms, owing to the increased PPE requirements. And our lab medicine colleagues also helped us starting an in-house testing that allowed us to have rapid test results and to decide the treatment options. Next thing we faced during this pandemic was the ethical dilemmas. As you all know, we had like high or the increased negative outcomes in our older individuals and also with people with multiple comorbid illness. So we need to have a discussion with palliative care, ethics consult, and also with the family. That was very critical during this time. And also we, as the hospital, in all our sister hospital also, our management encouraged our emergency medicine and hospital medicine staff to have a discussion or the conversation with patient and families regarding the goals of care, and also was clarifying their advanced directives regarding their code status. After all, the staff wellness was the most important thing we give much more importance, because this was a challenging time and it created a tremendous pressure and distress among the healthcare personnel, because most of the staff members have to isolate themselves from their families, either by staying in hotels or by sending their families away from them. So during this time, some of our staff themselves have created or updated wills and advanced directives for themselves. We had mental health care providers with expertise in the management of trauma and also acute stress to offer individual and group support to our staff. And also we had a 24-hour direct access to mental health professional to keep the wellness of our staff. Next is the ED protocol during the COVID-19. As you know, I'm like worked only in the critical care or in the ICU. I don't have much experience what happened in the emergency room, but this is the protocol we use once the patient comes with symptoms or when the patient doesn't have symptoms. So we have to separate them and what we did. So you can just go through the slides. Next is COVID-19 treatment guidelines. As you all know, there is no specific treatment for COVID-19 is currently available. All the treatments are largely supportive and ongoing trials during this time. So once our treatment includes prompt implementation of recommended infection prevention and control measures, infectious disease consultation. Then the next step was supportive management of the complications, include respiratory care. So for the respiratory care, we mainly followed the ARDSNet protocol. Then fluid management, we were very conservative in the fluid management because of the ARDS status. Then systemic corticosteroid therapy, we usually use in ARDS protocol, but in COVID-19 we were initially not using, but in the later part we started using low dose steroids. Next one is antimicrobial therapy. So that's used only when we found out that if people with COVID-19 have other superimposed bacterial pneumonia, then we started to use antimicrobial therapy. Then we had antiviral therapy. Those were all trial drugs. Then everybody is familiar with Plaquenil. Initially, when the COVID-19 hit New York City, everybody was using the Plaquenil. So initially we used like 400 milligram BID, 2 doses, followed by 400 milligram daily for 4 days. Then we had another trial with Plaquenil and also with Citromax, but those 2 trials were not showing any benefit on COVID-19 patients. Then we had institutional trial with Remdesivir. That is also an experimental drug designed to interfere with the virus ability to replicate in cells, and the dosage was 200 milligram IV on the day 1, followed by 100 milligram IV daily for 9 days. The trial result is also the efficacy is not concluded with that drug either. Next thing we used was immune response modulator trials. The drug we used was sarilumab, and the purpose of this drug was to prevent the dangerous complication that result when body's immune system goes into overdrive. The preliminary result of this ongoing trial also suggests that the drug is not effective in hospitalized, severely ill patients. Then the next step we used was convalescent plasma. So we started using that in the ICUs with severe ARDS patients. So initially we started using 1 unit of convalescent plasma. Then some people we had given 2 units, but it depends on the patient's clinical response from the first unit. There is still not a clear evidence that showing that the plasma is also helping, but still we are continuing convalescent plasma trial. The other drug we used was tocilizumab. That is a interleukin 6 antagonist that's used for the management of cytokine release syndrome. That has only one time use of the drug, that's 400 milligram IV, but there are so many criteria to use that drug. We should have a SARS-CoV-2 positive result. Chest X-ray should be consistent with COVID-19 imaging. Then patient has ARDS. Then persistent fever that's more than 38 degrees for at least 24 hours. Then 2 of the following criteria, either ferritin more than 1200 nanogram per ml or more than 600 nanogram per ml with doubling within 24 hours. Then D-dimer more than 1 microgram per ml or LDH more than 300 units, and also CRP more than 10 milligram per deciliter. We also used inhaled pulmonary vasodilators like inhaled nitric oxide. We used in some of the patients, we mostly used patients who had severe ARDS. So these were the treatments we used during our pandemic time. So now let me reflect on my COVID experience. I have 20 plus years of critical care RN and nurse practitioner experience. I never thought I would ever come across anything like this. But my years of experience had prepared me to help people during an unprecedented and unimaginable global crisis. We all felt ready to take on this new challenge that we faced, but no one could have anticipated the rate at which the patients would be coming through our doors. What really put things into perspective was seeing trucks that were once being used to deliver groceries now having a whole new purpose, serving as a morgue. In March, the peak of the pandemic in New York, I would walk into a unit that was filled with patients who were suffering from the most severe form of respiratory illness. As I had talked about earlier, New York Presbyterian Hospital accommodated this large influx of patients through structural and operational changes. Unfortunately, the patients' families could not be there in person to support their loved ones. I found myself serving the role of a clinician and as an advocate and emotional supporter for my patients and their families. I also found communicating with families through Zoom and FaceTime, often delivering bad news and making tough decisions through the phone. Then I faced with another challenge. Having a family to go home add another challenge to my plate. I faced 2 options, either to go home after work and risk infecting my family or go to a hotel after work and not to see my family. This stress, along with the stress of having a responsibility to the public and my patients, left me worn out but motivated. The main thing that got me through this tough time was the amazing team, our hospital, and the support from the community. Our community supported us in our efforts in the form of free delivered meals, fruit baskets, skincare products, and protective gear. The people of New York thanked all the healthcare workers through chants, sirens, and clapping at 7 p.m. every day. Moreover, all staff members were being redeployed to take responsibilities that were not typical to their positions prior to the pandemic. I personally was moved from the neurology step-down unit to a neuro ICU. However, I adapted with no complaints as I recognized the huge responsibility that I had. We always had each other's back. I am extremely grateful to my colleagues and the environment they created. They supported me, provided me with a shoulder to cry on, built me up, and encouraged me. Ultimately, this challenges unified as a cohesive team. This has confirmed one thing for me. We are built for this. I am built for this. Crisis is known to bring out the best and the worst in people. But I can confidently say that while facing this challenge, my colleagues and I brought our best to work each and every day. The takeaway from me to you, ultimately, you have to take care of yourself. Self-care is so important. There are so many people who walk into the hospital buildings every single day who are absolute heroes, caring for each other and the community they serve. But please remember, one of the most important things is to take care of yourself first. Stay safe, stay healthy, and keep inspiring the world with the work that you are doing. Self-care is not selfish. Thank you for giving me this opportunity. And now, if you have any questions, I'll take this time to answer your questions.
Excuse ma'am, can you hear me?
Yes.
Like what is the current scenario in the US now? Because whether you are taking all the positive patients to hospital or whether they can stay back at home and only symptomatic patients need to come to hospital. What's the situation there now?
Right now in New York, our situations, our current status of number of patients are less than 1%, but in other parts of the US, the number of cases are rising. They are not getting admitted, all positive cases. Some of them are managed at home. And we learned the lesson from New York, so now all other states are managing the patients much better than New York handled.
Thank you, ma'am. Dear participants, any questions you want to, you can do a chat now, or you can, yeah, you can put in the chat box now. Okay, no more questions are there. So thank you so much, ma'am. Thank you for your wonderful presentation and your reflection and your personal experience. And we salute you and your team and the entire nursing fraternity on behalf of our college also, because on hearing the presentation itself, we understood that how much pain you are undergoing, the stress. Anyway, thank you so much, ma'am.
Thank you.
Next, I would like to welcome Ms. Jasmine Bipin Anthony, certified anesthetist, US. Over to you, ma'am. Participants, please wait for 1 minute. Ma'am will join soon.
Hi, give me a second, I'm coming. Hi, can you hear me?
Yeah, ma'am, we can hear.
Hi, good afternoon all. I'm Jasmine Vibin Anthony, certified registered nurse anesthetist. I work for Fairfax Anesthesiology Associates. I work at Innova Fairfax Hospital, Virginia, United States. Nice to be with you all at this time. I have a very short presentation because Ms. Shinda Jose covered pretty much everything about COVID-19 pandemic. As soon as the COVID pandemic started in New York, our hospital began preparing for the surge of COVID cases in our area. As a precaution, we stopped all elective surgical procedures, and our anesthesia team formed a care team to respond to all COVID cases intubations. The care team stands for COVID Anesthesia Intubation Response Team. Today, I'd like to share about our anesthesia department's response to COVID pandemic. We made ourselves available 24 hours a day to go and intubate any patient who was in need of ventilator support. To do that, we staffed 2 clinicians for 12 hours during the daytime and 2 clinicians during nighttime. So we rotated ourselves. Our hospital have around 1,000 beds with 275 ICU capability. And we went to all the 3 different emergency rooms and all the 5 different ICUs whenever they needed a patient to be intubated. So in the early phase of COVID-19 pandemic, early tracheal intubation was recommended instead of BiPAP or high flow nasal oxygen. But that changed tremendously. Now the goal is to prevent or delay intubation. When a patient needs to be intubated, the intensivist or ER attending will trigger a COVID intubation response. Then the care team will respond with appropriate materials for safe intubation. Care team consists of 2 anesthesia providers, and we were assisted by a RN or a respiratory therapist in the ICU. This is me, actually not in an ICU, getting ready to intubate getting ready to give anesthesia to a patient, a COVID-19 positive patient, whom we had to do an emergency brain surgery because of a big tumor, and he presented with stroke, and we couldn't delay because he already had a shift. I will talk about more about the PPE in the coming slides, but I just wanted to show a picture. The intubation process. One anesthesia provider will don PPE and enter patient room, and the second provider will remain outside in case if the first provider needed any assistance if the first attempt fails. The respiratory therapist will have ET tube with glide scope, working suction and Younger, viral filter on ambubag, and ventilator ready in the room. We used high efficiency air purifying filters for all intubations on the circuit, so that in case all the secretions which gets aerosolized will not go into the ventilator or into the atmosphere. We used video laryngoscope for all intubations for 2 reasons. One, for optimal first pass success. Second, when we do DVL, we had to be near the patient's face, but when we use video laryngoscope, our face could stay a little far away from the patient's face. We pre-oxygenated all patients for 5 minutes with 100% oxygen with a very tight seal with ambu bag with HEPA filter on it. Positive pressure ventilation, high flow oxygen, and manual bagging only if clinically necessary. I just want to focus on that. On a normal intubation process for a regular patient, when we give anesthesia, we normally make sure before we give, after giving our sedative, we normally make sure we can successfully bag a patient, and then we give our muscle relaxant and then manually bag them for 3 minutes. But for the COVID-19 intubations, we totally avoided that. Instead, we only did pre-oxygenate for 5 minutes with 100% oxygenation. We performed rapid sequence intubation to avoid aerosolization of virus with small respiratory droplets from bagging. Upon intubation, immediate endotracheal cuff inflation and insertion of HEPA filter before positive pressure ventilation was instituted, so that again, the main goal was to decrease the respiratory droplets into the atmosphere. We limited ventilator disconnects, clamped ET tube during disconnects, and always disconnected after distal to the HEPA filter. And we followed doffing guidelines and exited the patient room. So my interaction with patient was very critical, but it was for less than 5 minutes. Supplies ready inside the room. This was prepared by an RN or respiratory therapist when they call for care team. So when I get there, this was already available in the room. Glide scope with blades, size 3 and 4. LMA sizes in different sizes. We kept it just in case if we missed our first intubation to reinsert and make sure we could bag the patient through the LMA. ET tube sizes with the glide scope stylet, 10 cc syringe to inflate the balloon, and oral airway and tongue blade just in case if we had to bag mask if the patient was desaturating. And all patients required a HEPA filter and a clamp in case if we had to disconnect the endotracheal tube. And of course, the drugs to intubate, propofol or etomidate, succinylcholine. Whenever succinylcholine was contraindicated, we used rocuronium, lidocaine 2% to decrease the burning sensation from the propofol and the rocuronium, and eosinophil syringes to treat the hypertension which occurred from the medications of intubation. We carried with us a PPE bag which had an N95 mask, paper hood and filter unit, surgical gown which was impermeable, and a yellow gown which happened to be the color in our hospital, but basically a semi-permeable procedure gown, gloves and shoe covers. And we also had an airway bag which included pretty much the same thing which the RN or respiratory therapist had in the room, but this was just in case we needed extra. And of course, the medication bag to intubate, same medications I mentioned earlier. American Society of Anesthesiologists and American Association of Nurse Anesthetists believe that the safety of anesthesia professionals is of utmost importance in developing policies related to personal protective equipment. ASA and AANA recommended all anesthesia professionals utilize PPE appropriate for all aerosol generating procedures for all patients working near the airway. For aerosol generating procedures, PPE includes eye protection, which is goggles or disposable face shield, gown, gloves, and airway protection with N95 masks or PAPRs. PAPR stands for Powered Air Purifying Respirators. At our hospital, we decided to use PAPR on top of N95 mask for all aerosol generating procedures like intubation, extubation, TEE, bronchoscopy, etc. for all COVID positive patients and N95 for all patients. Use effective hand hygiene before putting on and after removing PPE, including gloves. Just like intubation was important, donning paper and doffing paper was also very important. It was a two-person exercise. While the first person is donning, the second person, also called as spotter, reads the checklist and assists the first person. The first person, who is assigned to go inside the room to intubate the patient, get ready by removing everything from their jacket, pull hair back from face, and don shoe covers. They perform hand hygiene with hand sanitizer, don the yellow gown or the impermeable gown, and they put on the paper blower unit and belt, and don surgical gloves and the paper hood, the surgical gown, and the outer non-sterile gloves. If I just read this presentation, it may not really make any sense to you, because in case if you are not familiar with paper, you will not have any idea what I'm talking about. So I'm actually going to stop the presentation right now. I'm midway. I'm going to show you the video so you will have an idea what I'm going to talk about the rest. Give me 1 second. This was a video we created in our department before we started getting any COVID patients. We were just preparing for the COVID pandemic. This is one of my two colleagues.
Remove lab coats, jackets, items from pockets, jewelry, badges. And each person donning a PAPR shall be assisted by a member of the staff who's not donning PPE. We'll pull hair back from face and secure. We'll make sure before we start donning to check our devices here. So we have a VersaFlow PAPR we're using. We'll check the apparatus itself. We'll check the battery here. Give it a little test. We'll see all the full bars. So we're ready to go. We'll go ahead and put it on. Yep. Turns on. You hear that extra click, so you know it's nice and secure. And you press this button, turn on button right here. To turn it off, you hold it down and it turns that off. All right, so now we know our apparatus is working, and then we'll also check our PAPR hood, inspect it for any, it should be clean, but make sure there's no break in the hood, and it's the correct size for you. Great. All right, so we'll start off by putting on a knee-high ortho booty there. It's helpful to time too, because otherwise they'll actually continue sagging.
Can you hear?
This is our clean table too.
This is our clean
everything
table
here
we're
is
starting.
clean that we're starting with. So we're gonna have a dirty table soon.
We have hand hygiene gear, sanitizer, non-sterile gloves, sterile gloves. Everything you see here should be in your go bag already. We've just taken it out for ease to demonstrate. So that includes a sterile gown and also a yellow PPE gown there.
അതെ പേഷ്യൻസുമായിട്ടുള്ള
interactions
ഇന്ററാക്ഷൻസും എക്സ്പീരിയൻസും
we can go ahead and insert, if it's not already, insert the PAPR hose into the blower unit, which this one is already inserted, and you want to also size it. So
Which I did.
yeah, we already sized that, so that's the right size for that for sure. Okay. So first up, we're going to don the inner yellow gown. You want to be sure to cover the back by tying it all the way around so that you have, got it? Perfect. All right. So back is totally covered here with our yellow gown. Next up, we'll put on the PAPR blower unit and belt.
This is a little different than what we've previously has been recommended for, because we're double gowning. It's
Correct.
different than what you'll find on other videos.
So yellow gown
And-
first and then PAPR lower unit on. Okay, it's nice and snug. It's not gonna keep falling down there. All right, so then next up, we will go ahead and put on the surgical gloves for underneath. The inner gloves are the surgical gloves that we're wearing. We want the length, that's why we decided to go with these. They don't have to be sterile, obviously, we just need to do the long one. And that's what we have on par for the long gloves, is the sterile ones.
Thumb through the thumb hole.
Correct.
Try and keep your arms covered consistently.
Try to pull it back as far as it'll go without hopping your gloves. Okay, great. Next, we will don surgical gown.
We're gonna do the PAPR before the gown.
Okay, great. So we will go ahead and do this for ease of tucking in the shrouds. So our PAPR hood has 2 shrouds here. We've found that it'll be easier to put this on in between the 2 gowns to tuck the shroud, the outer shroud. So we'll go ahead and put the hood on. Okay, and there's a great band right there inside of the PAPR hood that needs to go comfortably across the mid-forehead area. So that looks good.
Turn me on and give me some air.
So, so you can see the hose right here, you connect them.
I am your father.
All right, that's connected. I'll give it a little tuck to make sure. And we'll give a little ventilation to Dr. Darth here. Right. And you will see that our PAPR blower unit is still not covered. So nicely exposed. We don't want the vent to be obstructed there. Okay. We've got surgical gowns. Well, at this point, we'll go ahead and put on our surgical gown now. And we'll be sure to have that over both of the shrouds. So both the outside and the inner shrouds of the PAPR hood are tucked in underneath this guy here. And this just can help at this point. It becomes too much, it's hard to see. Okay. So be sure here to not obstruct the PAPR blower unit. Right, and then tuck it around. Okay, so you can turn around. You can see the blower unit vent is not obstructed. You can still, it has a way to take an air intake, but we're still nicely covered with the underneath yellow gowns, the PPE gowns. And so surgical gown is on, ensure blower air intake is not obstructed. PAPR hood is already hooked into the PAPR hose and we have ventilation going on. The PAPR has already been turned on. So, yep, non-sterile gloves. So we'll proceed to putting on the outer gloves, which can be non-sterile gloves. The most important part here is to fold in the cuffs, or pull them as low as you can towards the palm of your wrist. So that as much of the cuff of the outside gown is covered with your outer gloves. So yep. So now we have nicely covered the cuff of the outside gown there. So double gloves and double gowns there. And at this point, the spotter will do an extra check before we go into the room. This is nicely covered. If there's any issues that you see with the PAPR, especially make sure that the vent is not occluded. If you see any leak or break, make sure to let them know. And once the intubator goes into the room, the spotter would then proceed to put on the yellow gown, at least one pair of gloves, a mask of your choosing, and a face shield. Because you will then be outside of the room waiting. If you're needed in for assistance, you're halfway donned in. And if not, when they come out, to help clean the intubator, you're going to want to be in that PPE. So yellow gown, pair of gloves, a mask, and a face shield.
But
That's
the
it.
other person also has a full PPE with them if they really need to go in another
Correct,
gown
yes.
and their capper.
Right, yeah, so that way you're kind of halfway done and you can throw on your popper hood, connect onto your belt.
So appear this powder.
We're gonna perform the popper doffing procedures now. So we've already intubated the patient and Dr. Durst is inside of the room. This is the door. I'm outside in the hallway. So step one, prior to exiting the patient's room, you inspect and disinfect any visible contamination using disinfectant wipes. Dr. Durst doesn't have any on her right now. So while inside the patient room, she removes the booties first. Once the booties are removed, we will go on to removing the outer surgical gown and gloves together. So we'll remove the, from the nipple line area, pairs down and away from your body, forward, and you try to circle it into the ball, rolling it on itself, and you discard in the trash. You try to have your chin up so you avoid the neckline of the gown touching. Great. And
Then, yeah, your head fell.
so if you use the Vitoscope in the room, you perform initial wipe down at the Vitoscope with Oxivir wipes. We are not using our own Vitoscope in this instance. We use the staff's Vitoscope, so it remains with them for them to take care of. And the Vitoscopes at this time we're using are disposable, as well as the blades. So then we perform hand hygiene using hand sanitizer. Okay, and Dr. Durst will exit the patient's room with a PAPR on. And here at this point, I will have severe wipes for her to step out onto. So she's doing hand hygiene inside of the room and then steps out there, and then hand hygiene again outside of the room. Right, so at this point, this is where the system will come in handy. The assistant would, so at this point, the assistant would wipe the popper hood while it's still donned on Dr. Durst there. You want to be systematic about this and try to clean from the least contaminated area to the most contaminated, so from the bottom up, because this surface here was covered by the surgical gown, even though it's still considered contaminated. So you start from the bottom here. I'll definitely be more thorough and meticulous if this was real patient's scenario. And filters the screen here, plastic screen. All right. So that's the outer layer. I use different wipes for the inside of the outer layer. Okay, and then I throw those ones. And then again, new set of wipes for the inside shroud. And then again, a new set of wipes for the inside of the inside shroud. So pretty thorough and careful cleaning there of the top of the bed. So here. So the assistant has wiped the top of it. Yeah, the assistant has wiped down the top of it at this point while the intubator is still wearing it layer by layer. And after the popper hood is removed, be careful to not touch your face or hair. So Dr. Durst, well, this is our clean surface we're working on here. Or, sorry, not clean, but dirty, but rather where we put our popper hood onto, as well as the lower unit and post. So we will, Dr. Durst will go ahead and remove the popper hood with one hand underneath the chin and the other hand reaching over the connector. Yeah, so instructions say do that way. And if you need help, the assistant can always spot you.
My glasses are coming.
So I can help you.
Yeah.
So this way, so he is away from you.
Yeah, I just have my glasses.
So we'll go ahead and set these here.
Thank you.
This is clean now for the moment.
Don't touch my face. Great.
So, all right, so we're careful to have our PAPR hood onto the surface here. And while I was cleaning the PAPR hood too, one thing I forgot to mention, I would clean the PAPR hose in the back that connects from the hood to the blower unit, as well as the blower unit itself, really thoroughly. So that way it's considered clean now. The PAPR hood's been cleaned, the hose has been cleaned, the blower unit is clean. And Dr. Dirk will go ahead and do a hand hygiene with the inner gloves and inner gown on. Surface. Remember, hood will be attached to the PAPR blower unit, still a partner. That's me with doffing. I'll assist with doffing. I'm wearing gloves, and the blower unit is removed at this point. So we can disconnect. Partners doffing, wearing gloves. Hold head of blower unit is removed. So I will hold the hose and the hood here for Dr. Dirk while she disconnects and places it here by our surface. Great. So at this point, this was cleaned. It will be cleaned again, but that was just this part in removing it. So at this point, you can go ahead and remove your yellow gown and your inner gloves, sterile gloves together, away from you. Being careful not to touch your chest or arms. Chin up, away from you. Yep, perfect in the bowl. Sure. So the gloves and gown were removed. And at this point, you do hand hygiene. Yep, when in doubt, hand hygiene. Okay. Then another set of gloves, and you go back to cleaning all your supplies all over again. So as you can see, the initial wipe down wasn't going to be the last of it. It's just the initial wipe down to help clean up any exterior contamination. But you'll want to do some more thorough cleaning again, decontamination with the Oxygen wipes on your setup right there. And once you've done that, you throw away your gloves. Also decontaminate the surface that you used to set all this stuff on, as well as the Oxygen wipes.
Hi, back to the presentation. I hope you all got an idea. This was a video we made initially, even before the first COVID case came to our hospital, so that we were ready. Once we started our care team, we didn't really get a chance to do any videos. So there was a lot of revisions, but this was the basic video we started upon. So just like doffing the PAPR is also very important. So I just wanted to share that video with you so that you will have an idea about what I'm talking about. Back to doffing PAPR. Doffing is the largest risk for contamination. So remove the outer gown and gloves, perform hand sanitizer, exit the patient room with PAPR still in place. So the outer gown is removed and the booties are, shoe covers are removed while you are in the patient room. And then you exit the patient room with the PAPR hood still in place. And the assistant will wipe the PAPR hood with Otsuber wipe before removing it, because when you remove it, if there was any particles on the PAPR hood, there is high chance of contaminating yourself with that particles. So that's why it's very, very important to really clean it before you remove it. So wipe from least contaminated area to most, bottom to top. Also wipe hose and blower unit. Remove the PAPR hood with very care. Remove gloves and gown, perform hand hygiene and don clean gloves. And we again disinfect the PAPR hood because we already disinfected once, but still there is a chance that it couldn't be 100% clean. So we disinfect it and we let it air dry and hang it in our PPE room so we can reuse that. So we reuse it until there is no damage in that paper hood. So each person in our department was assigned a paper hood. Depending upon the sizes, the head circumference measurement was taken, and it comes in small, medium, and then medium large. So each person was assigned a paper hood, and we kept reusing it. And we we had a designated surface area to disinfect it and store it. And hand hygiene was always important. Changes in our department. All patients were tested for COVID prior to any surgeries, and we still continue to do it. Only negative tested patients are allowed for elective surgeries. Emergency surgeries are conducted for COVID positive patients. All non-tested emergency cases were treated as PUI, which is person under investigation, which means we used all precaution just like a COVID positive patient for a non-tested emergency case. Full PPE for all COVID positive surgical cases and PUI cases. That's all about the COVID-19 pandemic intubation process. Personally, if I have to say, when I usually go and intubate a patient or take a patient for surgery, I usually get a chance to interact with them before I take them back to operating room. That's the time I evaluate them. I introduce myself, I talk to them, give them some relaxing medication and take the patient back to the operating room. But in this scenario, I was entering the patient room fully covered. I couldn't talk much at that time because even if I talk, nobody can hear me because I was all covered in a mask and then hood and the paper device running. And also the patient was not in a communicative situation. The patient was so anxious, so fearful, and always had an impending doom of what's going to happening to me. It was really upsetting to see a patient in that situation, but I didn't have much time to interact with the patient at that time. My main goal at that time was to put the breathing tube in them as soon as possible and connect them to the ventilator. So my interaction with the patients was very, very minimal, but it was very critical. I feel like I've helped in my own way. And if you have any question, I will take it right now.
Okay, ma'am. Any problems or any challenges you faced during the intubation procedure?
The main challenge during the intubation procedure for me was seeing the desaturation of the patient. Which means basically normally when I intubate a patient, we pre-oxygenate the patient and then we give our sedative and muscle relaxant. During that time, we back mask the patient. So very rarely we see a patient desaturating, but very commonly when I intubated a COVID-19 patient, very commonly we saw that they desaturate. There are a couple of reasons for that. Of course, as you all know, respiratory system was the most affected during the COVID infection. And most of the patients who required intubation, I saw a pattern. Most of them were morbidly obese. That itself will put them at high risk for desaturation because they don't have much reserve for oxygenation. Usually I start with 80 to 85 saturation level. And then when we pre-oxygenate, it may come up to 92 to 94. Very rarely I saw above 95% saturation. And Normally, between the time I give the medication and I intubate, it didn't take more than 45 seconds. But within that 45 seconds, I have seen saturation going down to 20s and 30s. But I had the confidence that the tube is in and it will come up in a few seconds. So we had already educated the nurses and respiratory therapists that this will happen and there is no need to panic. The saturation will come up once we connect to the ventilator. So normally the saturation comes back within 2 to 3 minutes to back or better than what it was normally.
Jasmine, sorry to ask you, they intubate all the patients who intubated survived, or there was any problems?
So I won't say that all of them survived. Out of the many patients we intubated, many patients didn't do better with ventilation. So we moved further to ECMO, extracorporeal membrane oxygenation. And even with ECMO, many patients didn't survive, unfortunately. It's mainly because of the comorbidities they had. But many patients did survive and got extubated. It took at least 10 to 15 days to even do an extubation trial in the beginning. So eventually we decided not to intubate the patients early. Instead, we tried to keep them on high flow nasal oxygenation or BiPAP or other supportive treatments because intubation really it helped, but it did not really made a big difference in their survival. So we tried not to intubate. And in the beginning of our care team, we saw there was like 4 to 5 intubations daily in our 12-hour shift. But towards the end, we did only 1 to 2 intubations in a 12-hour shift.
Thank you.
Any other questions about intubation or?
Jasmine, one more thing. Is it okay to explain the journey towards CRNA? Just for my students, this will be motivating them. So just tell us the type of job you are doing. Actually, it's amazing. So it's actually, we like to know how was a student life as CRNA, how you did it.
Sure. When I did my undergraduate nursing program, I was your junior. And during that time, I actually wanted to do my MSN. I didn't have any plan to come to United States. I wanted to do my MSN in administration. But soon I got married. I came to United States. And while settling in United States and raising my family, higher education took a backseat. And but while I was working in ICU, I was also an ACLS instructor. I was very active in my ICU community. I was part of many critical care team councils, and I was very enthusiastic about it. And I was a part of rapid response team and Code Blue team, which means around you might already know what it is. But we responded as an ICU nurse, I responded, and I saw that CRNAs came and intubated the patients in emergencies. And I thought that was so cool. And I admired them so much because it was very cool to watch a nurse come and intubate a patient. And I looked upon them and I really wanted to do it. Given my situations, it was not easy, but I really wanted to do it. So I worked hard for it. It took almost 3 years for me to enter into the program once I decided that I wanted to do it. Because it was almost 10 years since my undergraduate program when I decided to do my master's. So I went back and did a couple of master's courses in pharmacology, pathophysiology, biochemistry, and statistics to prove to the university that I'm still capable of studying. So I did that, and I applied to one of the best program in my area, which was Georgetown University. I didn't get in first time. The applicants, there were 400 applicants and there were only 25 seats. very competitive. But during that time, I did my master's courses, and I got a grade in all my courses, and I got in the second time. So I proved that I'm capable to do it. So they accepted me. And the next 3 years was very challenging, way more than I thought it would be. Being one of the most oldest person in the class. Most of my classmates were young, didn't have family. It was really challenging coming from another country. I didn't have my undergraduate degree here, so I was not used to all the program curriculum. Not only that, I didn't have any income for 3 years because I was not allowed to work. It was full-time study. All these things added challenges and difficulties to my situation, but my perseverance, my family support, and of course, Almighty God's grace helped me through it. And I finally saw light at the end of the tunnel. I graduated and I passed the national licensing exam, and I pursued my career in anesthesia. I'm very happy that I did it because I really love what I'm doing now. I have autonomy in my practice, which means I evaluate my patients preoperatively, and I do the main 3 phases of anesthesia, which is induction, maintenance, emergence, and also post-evaluation. And I give all my medications. I don't need a doctor's order to give medications. So I love the autonomy. I'm very happy.
We are also proud of you, Jasmine, as a senior, I have to say that. And motivation, that's why I asked you. Thank you so much.
Thank you, ma'am. Thank you so much. And it's really motivating. And many of our students are also watching this session. And like, hats off to you. Thank you so much.
You are very welcome. I want to tell all students that if you set your heart into something, you really can do it. Anybody can do it. When I did my nursing, I didn't have any idea that I would be doing this one day because I didn't know. But when I worked as an ICU nurse in India, I always looked upon the anesthetists who were there, they were in charge of all the patients and in charge of everything. And I used to look upon them admiringly. And when I saw an opportunity that I could do it, I jumped up for it. And I'm sure all the nurses out there watching me can do this. Set your heart upon this and you can.
Thank you for your motivating words and thank you so much. Yeah, next I would like to welcome Mr. Daniel Wilfred. He's a clinical nurse specialist from Australia. There's a last session. I welcome you, sir, to the session.
Hi, good day, everyone. My name is Daniel. I work in Walker Base Hospital for 8 years. I'm a clinical nurse specialist in infection control, and also I do a bit of afterwards nurse manager. It's a bed management. Today I pay my respect to the Wiradjuri community, who are the past and present leaders of this Australia. You can see my hospital picture near to my designation. I'm part of the NSW Health Murrumbidgee Local Health District nurse and also nurse manager. Today, I'm happy to say Happy Teachers Day. Without them, I feel I'm nothing in nursing because I learned a lot of things from my teachers, from my mentors. Thank you for the opportunity for the Gokulam College of Nursing to giving me an opportunity to share my experience on this day. And thank you and happy Teachers' Day for all the teachers. I'll start with a background of what happened in Australia. So I'm going to talk about trends and issues in Australia from the COVID. I'm not going to talk much about medical management. I'll be touch a little bit of things about ICU. I will be talking about the bed management issue. I will be talking about health constraints in the part of the business, what's happening in the health industry in Australia. And also I'm going to talk about the, how Australia is coping up COVID-19, this pandemic season. The first case was identified in 25th of January 2020. That is came from the traveler who traveled from Wuhan. The reason is in most of the part of the Australia, the business and the educations, it's all the participants from China. And the main sort of strain we get in Australia is SARS-CoV-2. And as of today morning, our confirmed cases are 26,207. If you compare to the other developed countries, Australia did really very well by containing this very pandemic and dangerous virus. Today, as of now, actively, we have 2,730 active cases, in which 450 of them are hospitalized. Apart from that, there are 27 patients in critical care in ICU. So far, we had 748 deaths. So just a touch of Australia, the geography. We are blessed with the geography. If you look at the right-hand side of my slide, that's an Australian map. You can see Australia, it's surrounded by the sea. So we don't have much of movement between the other countries. Australia has the population of over 25 million. It almost a continent. Australia is a continent. We have 6 states, Victoria, New South Wales, Queensland, Western Australia, South Australia, Tasmania. And we have 2 territories. One is Australian Capital Territory and then Northern Territory. If I go back further, Victoria is in second phase of COVID-19. So far, we got 19,138. So Victorian border is closed. Victorian state is closed at the stage because they are in stage 4. It all happened last 6 weeks because of the community transmission, and also some of the restriction has been eased after the initial first phase. And also we had a mass rally, and also we had some other activities, sports activities. So that was the reason. You can see Victoria has a big spike and also big surge in the COVID cases. New South Wales, which is our state, it's 4,063 cases as of today. And Queensland is 1,124, and Western Australia 655, and South Australia 463, and Tasmania is 213, and Australian Capital Territory is 113, and Northern Territory is 33 cases. By saying that, if you look at the last 2 territories, I think almost more than 8 weeks, there is no new cases. And also Tasmania has no cases more than 2 months. And South Australia, it's only 4 or 5, and Western Australia, 2 or 3, and Queensland, 4 or 5 every day, and New South Wales is around 10 or 15, very minimal clusters. And Victoria, as if last 3 days, it's in 2 digits, maybe 80, 40s, and 70s. Just going back to the basic principles, what we're doing in the hospital, as well as in the community, what we're doing. One of the main thing what we're doing is the hand hygiene. So we are following a strict hand hygiene for a longer time in our hospital. I can proudly say that I'm one of the hand hygiene auditor and also gold standard. I can train the trainees of hand hygiene. So our hospital always stand out of 95%. So we have done the providing a hand sanitizer wherever it is possible. Every part of the hospital, and anyone can use it, and anyone, whatever they want to use it. And also we want to make sure they follow the principles of hand hygiene very well. And also the other one is cough ethic. In that we train them, community in the school and also in the hospital, how you manage your cough, how you control them, and what way you use the mask, and what way you use your hand, and what way you will dispose the tissue. And also body checks. You have seen that what happened in the previous presentation from the presenter, how they're doing it, donning and doffing, how they are preparing the PPE. So we do a body check, what the other person will check everything for you, make sure you're fully covered and you're entering into the zone where is the COVID person is occupied. And also we have, these are all the main thing what we do in the hospital in all the areas. If you look at that ED PPE flow chart, I couldn't put the flow chart because it's a bit too much for you, and also it takes some time to explain you. So I just detailly explain the ED PPE. We have 2 sorts of triage system. When the patient comes to the ED, we will check whether they're fitting into the COVID zone or they're non-COVID patients. If they're non-COVID patients, they will be triaged and they will go into the ED zone, and they will be triaged and properly allocated the team to take care of them. And if they fit into the COVID zone, if they have any exposure or if they have symptoms of COVID, there is a different triage system. They don't go to the ED, they will directly go to the EMU. They won't allow, they're not allowed into the ED. So they will be pre-triage, and the nurses and the triage team will do the proper PPE, protective equipments. They will be covered with all the PPEs, and the patient will be triaged, and they'll go to the EMU, and then from the EMU, so we modified a part of the EMU as a hot zone. We call them hot zone when the patient the COVID query patients going to the ED or secondary ED, we call them hot zone. So there will be full preparation of drill happening there. There is a flow chart there. So we follow the principles, we follow each things. We make sure patients are safety and staff are safety and the community is safety. And we make sure we follow everything. So from there onwards, we will allocate them. And we follow the contact, droplet, and airborne precaution. It is closer to what we have seen the previous slide. So I don't think so. I need to explain further. And also we have a team leader, in charge nurse for each shift. So in the case, the team leader, we have multiple team leaders in ED. We have multiple team leaders in EMU. We have multiple team leaders in ICU, and also we have multiple team leaders in everywhere on the floor. So these team leaders will communicate and they will do the navigation of the patient, where they are going to and what we are doing. That's about the main principles. And just going back, to the staff visitor screening because we found that most of the transmissions are happening to the staff, because when they're coming to the work and when they're going back, they are high risk, and also the visitors. So we formed an emergency visitor system in which the patient visitors are only allowed in a particular time, and only one designated visitors for one patient for the entire admission. For example, any patient visitors coming to the hospital, there'll be one visitor. For example, Mr. Thomas coming to the hospital, his wife, Mrs. Jane, will be coming to the entire visiting for the entire admission. So it's only one designated visitor. So what happened, what was the outcome was, we can easily contact trace them who is coming to the hospital. In that case, we have minimized risk, and also we contain the visitors' movement. And also what was the outcome happened is there is less traffic in the hospital. Our car parks, our cafeteria, everywhere, it was very well contained. And also we also support the visitors. We have taken care of the mental health aspect as well. We're giving the adequate information, education for them. So that's about the visitors. And for the staff, when they're coming into the hospital, they come into the different entry point, not through the ambulance bay or not through the patient entry point. So we have a designated visitors and also staff entry points. Every staff will be screened prior to the work. So if they are 37.5 over a temperature, and also if they show any respiratory symptoms, even mild or whatever, and if they feel they are not fit, they're not allowed to get into the workplace. Either they are gone back to the clinic and they will be swabbed, and there will be 48 hours of self-isolation and quarantine, and then they will be cleared. And also, we have a question is if any staffs are coming from the hotspot or any clusters. For example, at this stage, all over Australia, Melbourne is the hotspot for us. We are part of the Sydney. So when anyone is coming from Melbourne travel, Melbourne Victorian border is closed. So if anybody is coming to that, they're not allowed to enter into the NSW border unless until they have a genuine reason, if they are essential worker or if they have any life-threatening condition to any of their family members. So with this, we are doing a great job of containing the infection rate, the COVID spread. And also, initially, within the 3-4 days itself, we got a strategy how we can minimize the traffic in the hospital. If anybody coming with, because in Australia, now it is a winter. We just finished winter last week. In winter, we have flu season. It is influenza A and B, mainly this time. So we want to segregate them. We want to make sure we are not combining the both symptoms and treating them wrongly, or giving them any negligence between the COVID and also flu. So what we have done, we have in all over Australia, we have done the COVID clinics outside the hospital. If any person having a COVID symptoms, so they will be with the mild symptoms where there is no life-threatening condition, they will be they can contact COVID clinics and they will do a swab. So there will be 2 types of packs you can see in my slide there. One is blue pack, one is yellow pack. In the blue pack, it's it called as level 4. Level 1 face marks. There will be 4 face marks where once the test is done, they're waiting for the results to come. So initial days of COVID, we got the results in 48 days. But now we got the rapid test. So it depends upon if you're working in the school, or if you're an emergency worker, if you're working in a health system, or if we are really taking care of a person who needs to be, you need to be with them. So they fall into the criteria. So we'll give them a mask and we will self-isolate them at home for 48 hours. I will touch base later how they are monitored. And type 2 is yellow sort of envelope box. It has 20 face masks in it. People who have test positive. So with that, we have minimized the panic in the community. And also, we also made sure that the community is safe and also the patients are safe. And also we are minimizing the burden to the healthcare system. Going to the next slide, it's what are all the issues now in Australia. You can see in news and everywhere, the major issue is at this stage is we got, sorry. The major problem is residential aged care areas where we have issues in residential aged care, because in Melbourne, most of the cluster outbreak in residential aged care. Very sorry to say that, because the most of the death, I think the 80 to 90% of death from 758 deaths so far in Australia, most of the deaths are documented came from residential aged care in Victoria. So the strategies in place for residential aged care is minimizing the staff movement across facilities. In Australia, health staff can move from one facility to another facilities. They will be doing a multiple shifts in a day. They will be doing a 4-hour shift in the morning and another 4-hour shift in the evening from one nursing home to another nursing home. So we've done a minimizing a staff movement across facilities. And also we have done infection prevention control, staff training and competency requirements. Because what we have done in Australia, we have done a robust management system for infection spread by saying that we have called our retired nursing staff, retired health professionals to come back to work. So we have given them crash courses about ICU, crash courses about the medication management, just to renew their license to practice. And also we have trained our defense people, because the defense people are also part of our health tie system now, because of to contain the infection. So we called for the defense people to work in the community for the restricted areas and also border and security for the screening. So, and also we called the police to work on the force for restricted areas and also for screening areas. So these are all the areas we got additional staff by training them and also upskilling them and also giving them the confidence how we can combat this bad virus around the community. And also we got a very good, strong public health advice on screening and entry restriction system. So it's a public health system monitor them. So every day there is a data collection from each area, from each district, from each state. So it's going to the public health system. So we are monitoring from them what's happening, and we're giving a suggestion, we're giving additional supplies, and also we are giving additional resources. The other issue we had initially was the staffing issues, because it's like everybody in the world, because some of them are not happy, some of them we didn't have enough staffing issues, mainly the regional areas, mainly in some of the parts of Australia, we didn't have enough staffing to meet the demand of the COVID demand. So that was one of the main issues, staffing. So I will explain you what we have done to counter-attack this issue, and also our targets, because any business, anything in the world, it's our targets. It's not like letters nowadays, it's all numbers. So initially we had fall in our KPIs. We had fall in our ambulance service. We had fall in our emergency performance. We had a fall in our targets, like we couldn't meet our targets. There are a couple of patients had a fall in our hospital. There are a couple of patients had a pressure injuries. There are a couple of patients had a couple of unit had a medication errors. There are a couple of areas we couldn't respond to the rapid deteriorating patients. So our targets had fallen. And also other major problem we had around everyone around the world is a supply chain. Because as I said, with our geography, Australia is disconnected with other countries because of the sea, because of the water. So we had a trouble in getting the supplies. So we had managed, I'll explain you how we managed the supply chain. And also other major problem was economy. It has suppressed our economy, both as industry, both as a community, as a person, as an individual, in a health system. It has a huge burden on the health system. And other thing is a border closure. Most of my friends works in other state, not in New South Wales. Some of them work in Victoria. Some of them work in Tasmania. So the border closure came as Australians' habit of traveling across the world, across Australia. So the border closure has had a huge demand of the chain supply, the food supply, and also supply of every material and the people visiting each other. So it's all given them huge concern, and also mental health. Because Australia is a country where people like to spend most of the times in outdoor sports and outdoor activities. And also they are so much of social interaction with each other. Because of the isolation, because of the work from home, we had a huge spike in mental health, especially with the kids. They're not going to the school. Initially, some of the schools are closed. We had a remote schooling, and also people lost the job. It caused them huge mental trauma. And then the elective surgeries, people are waiting for the replacement, elective surgeries. People are waiting for a long waiting list because we have shut down all the elective surgeries to create a capacity in our facility to counterattack the demand of the COVID bed situation. So these are all the main issues we had in our health system, and the solutions. The solutions are very simple for the community. It is not a rocket science. We made it very simple to people to follow because the population in Australia is spread all over Australia. We have a metropolitan cities, we have a major cities, we had a regional areas, we had remote areas. There are some of the towns, I can't say towns, there are some of the places there's only 2-3 houses. So we want them, the information to transform to each and every person in Australia. So we have taken every mode to educate the people. So one of the things is social distancing, so 1.5 meter distancing between the person. It applies everywhere. For example, if you go to the shopping center, you have to be 1.5 meter. So how you calculate? So it is about the square meter for the person. So if the shopping center has the capacity before of 1,000 member in a shopping center or a stall, so now they reduced to 150. So if there's more than 150, they say we're not allowed to get in there. So wherever you go, entry point, exit point, many areas you can see the hand hygiene products. Everyone is encouraged to do a hand hygiene. Even in the shopping center, in the school, everywhere it was very compulsory and mandatory to do a hand hygiene. And the other one is the COVID Safe app. You can see me in my picture, the mobile phone carrying a COVID Safe app. So what's happening in there? So I think most of the Australians, I trust, around 75%, those who have smartphones have downloaded this app as a COVID Safe app. So what happens, this app will tell you if you are entering into the cluster, it gives you a warning you're entering into the hot zone, or if you're entering into the spot where you are susceptible for an infection. And same way, if somebody having a COVID swab done, and they will get the result in the app, they will be contacted. And also it's a contact tracing, because person diagnosed with the COVID, they are self-isolated in the house. So the public health system will monitor then their movement, whether they're coming out of the house. If they're coming out of the house, there are hefty fines for them. Sometimes the fines are very severe and the punishments are severe. And other thing is a QRS scanner. Now we have eased most of the restriction around Australia, again saying that except Melbourne and Victorian state, the QRS scanner, like now we have lifted most of the restrictions. The schools are functioning. Remote schooling's no more except in Victoria. Most of the state has a school system. Universities are closed. Most of the business are open with a restriction, like what I said, social distancing, a person square meter distance. If they have a restaurant, they should have all those things, COVID app and also scanning method. So there's a QRS scanner is, for example, if you buy any product, they will scan and they'll say how much it costs you. Same way you can scan it in your mobile phone, and it will enter into the website. It show you where you're going, which restaurant you are in, how many of you in that, and what's your mobile number. So if there is an outbreak in the cluster, if that they will notify you and they will ask you to isolate yourself, and they'll ask you to get a swab done, and 48 hours of isolation, get the swab done, negative, and you don't need to be self-quarantined at the home. And other thing is a pre-booking, and our churches are functioning now, our restaurants are opening. You can go to the funerals, you can go to the wedding, you can go to the birthday parties, but everything is a pre-booking. If you want to go to the church, for example, if you want to go to the church on Sunday, you need to be pre-booked 3-4 days before, and church has some restriction, like again, saying the social distancing and all the basic things. And other things that really helped was the telehealth. Going back to the mental health issues, the government put enormous amount of effort and also money into the telehealth system, where you can talk to them for the counseling, where some of the consultation given through for the telehealth system for the people, those who are with the disabilities, people, those who are having a chronic health issues like a diabetes, having a hypertension, having a cardiac issues, having a stroke issues, long-standing chronic health. So they're all being transferred into the telehealth system, where all the patients are tracked down and their health needs being met, attended. And so these are all the main things what we have done apart from the hospital, and also staff training. All the staffs are trained in the health system as well. Everywhere the staffs were trained, even in the restaurants, even you can name it, all the staff, they've done very well. And not only health, everywhere they are trained, everywhere they know how to monitor them, everyone know how to report and breach, or how you can educate them. So everything was trained for them. And also capacity in our hospital, in Wagga Base Hospital, where I work as a bed manager. What we have done, we have moved GEM patient to the private hospital, so the government will supply the money for the to the private hospital. And also we moved our CCU. I'm a part of staff in CCU. I'm a clinical nurse specialist in infection control for CCU. So we moved the entire CCU and angiogram and all the cardiac procedure to a private hospital. And also we moved all the day surgery cases to the private hospital. And also we have moved part of the elective surgeries, category 1, where there's a need for a surgery, we have done to the private hospital. With that, we got the capacity for bed capacities. We got almost 45 extra beds. And also we have increased our ICU capacity from 12 beds to 40 ICU beds. So when we move all these patients, all the units to the other places, we also had enough staff. We almost trained 150 staff for the ICU, apart from the normal ICU staff. So we've done a robust education system. We support the staffs who wants to train in ICU. We identify the staff who can be fit into the ICU in a circumstances where we need to have a more ICU capacity. We train them. I think what the previous presentation was done by Jasmine, she covered those things. So we have done all the robust training for the ICU train. We call the term as new to ICU. And ED and emergency management, emergency medical unit. So we remodeled the ED within 12 hours. We remodeled the EMU within 6 hours. So we provide them, the structure has changed. We have changed the way we operate our ED, the way we are taking care of the patient. And also the way we deal with our ambulance service, we made sure the ambulance is available for the community in a specific manner and a safe manner, and also support needed in ED and EMU. And if you look at that in the next dot point, I said lift, transport, and security. It played a massive role in containing COVID spread in our hospital. We had a designated lift system. We had a designated transport system. We had a designated security system. So we had a clean pathway, and also we had a hot pathway. The hot zone pathway is only for the COVID patients, whether they're going to the one ward for investigation. For example, patient coming with a stroke symptom, having a COVID query, and he needs to have a CT scan. In this scenario, what we do, right? You call the security, and security will close all the other doors and make sure there is a public announce system in the hospital. There is a patient going from EMU to CT scan room. So no one allowed to walk on the corridor. Nobody will be there except the security, nursing staff, and the doctor, and the ward. And also person who is taking them for transport. So after the procedure is done, we inform them the transfer is done. So the zones will be automatically open. And the main thing, the other dot points, what we have done is a COVID physician. So every 7 days, there will be a respiratory physician will take care of the COVID patients. For example, if the patient comes with the cardiac symptoms, having a COVID-like symptoms, so the COVID physician will clear the patient before any procedure, any invasive procedure needs to be done. Or if even the swabs are coming as a negative, they have to be cleared by the COVID physicians. So that's how the COVID physicians, so they will take care of the entire district. Our district, our regional area covers almost 12 hospitals. So that this COVID physician will have a team of doctors and also team of nurses. So they will give the information. They will closely monitor them, even though if they're going home from discharge from the home. So we will transfer to the telehealth system, and also we will monitor from them. And recently, not recently, last 2 months, we're doing a rapid testing. So we will get the results within 30 minutes. So the patients will be getting a treatment immediately, what needs to be done, whether with the COVID or without COVID, what we are doing. And also COVID clinics. So we have a COVID clinics everywhere. Even for every 2,000 population, we have a COVID clinics. We also have a mobile COVID clinics because of the remote areas, regional areas. We will inform them through the radio, through the television, There is a mobile COVID clinic, so they can go and check them if they are COVID symptoms. And also visitors policy, I already covered the visitor policy, and also border closure. So as soon as if we see a cluster, for example, today in Sydney, last Friday, one of the school teacher positive for a COVID. So the whole school will be closed. The whole, the term used as a cluster. So the whole school will be closed. Every student will be self-isolated and the family will be isolated, and they will be tracked down for 48 hours. And the deep cleaning of the school will be happening. So, and also border closure. If there is one district is affected, one cluster is affected, the border will be closed. So there will be army will be on the road, and there will be police on the road, and the borders will be closed. And also outpatient clinic and mobile clinics, and the patient, those who are having a positive and clear and they are at home, so we just follow them, how they are keeping up. So we have primary health centers well equipped to take care of the patients, and also again the mobile clinics. I just briefly done a flow chart for the cleaning process, but it's all covered in the previous slides, how they're doing, so it's nothing much for me to explain. Now, this is Australia. You can see the first two pictures. It is very heart-touching pictures. First two pictures is a bushfire. Australia had a very bad bushfire last year, last summer. It was November to January. We lost life, we lost homes, we lost friends and family, we lost everything. And you can see a firefighter holding one of our animal from the forest. So it was a time Australia gone through the turmoil of emotions and pain and loss and anger. And then in January 25, we got our friend COVID, and nothing to spare, gave more pain to us, and put a lot of trouble. And in that matter, very proud to be an Australian at this stage, being a part of Australian community, because Australians are always says that never die hard, mate. We will come through this. It is not hard. So the friendship and the sharing of our knowledge and sharing our emotions and supporting each other pain, what we have taken today as a webinar to share our knowledge, that's how we are going through. There is a way, there is a light, it's coming through. I hope this COVID will give us a new lessons to our human life, how the health should be taken care, and how the environment should be taken care, and how everything should be taken care. Thank you for the opportunities. Just shoot your questions. I'm happy to take your questions. Thank you for the opportunity. By going back to Bindu Madam, she was my one of my teacher in my college days. I'm very happy to share the stage with her, and also I'm thankful again. I'm thankful to all my teachers and Almighty for this time. Thank you.
Thank you very much, sir, for your wonderful session. Once again, I would like to thank all the speakers for spending your valuable time with us. Thank you, sir. And also, I would like to thank all the participants. Thank you. Thank you all.
Thank you.